Okay, we have Kayla Moore with us today with Agents of Change Continuing Education, and she is going to talk to us about multidisciplinary social work. And Kayla is an LMSW, and she is a primary therapist with the Recovery Centers of America. And I will introduce her in our learning objectives, and then we will jump into our conversation. But thank you, Kayla, for being with us today.
No problem. Thank you for having me.
Okay, so a little bit about me. I am a child and adolescent therapist with the Sibley Group in Washington, D.C. I primarily work with neurodivergent children. I do outpatient therapy, and I am working towards my play therapy credential. Play and expressive arts are really a part of my repertoire. And then also, I'm the founder of Agents of Change Social Work Test Prep, and which is where Kayla found us, which is really cool. She passed with us. And then we wanted to move to the continuing education space so that mental health professionals and social workers could continue their learning journey. And a little bit about my interests. I love play. I love learning about the brain. I'm also very into technology and how it intersects with social work. And then lastly, I am, as if I'm not busy enough, I'm currently a DSW student at SUNY Buffalo, and I will graduate next May. And what I'm studying with my DSW program is supervision, and specifically multicultural supervision, how supervision conversations can be centered around multicultural identity and intersecting identities. So making sure that our BIPOC and minority clients are getting the highest level of care so they can have the best outcomes. So that's a little bit about me. And now I'm going to tell you a little bit about Kayla. So Kayla is an LMSW, and she has worked in, we were chatting before we hopped on, worked in pretty much a variety of different places. She has experience with adolescents, adults, veterans. She's currently in inpatient care. She completed her Bachelor of Arts in Criminal Justice and Corrections from Goldie Beacom College. And then she got interested in her work and furthered her education. She's committed to social welfare. She has her master's from Delaware State University. And professionally, she currently is a therapist at the Recovery Centers of America. She's going to tell us a little bit more about that work. She was just telling me she has a variety of different things. It sounds like she does a lot of things throughout the day. She does group therapy, crisis intervention. She meets with multidisciplinary teams, which we're going to talk about a little bit more. And she worked at Wilmington Veterans Affairs and Kent County LIC. And now she works with risk assessment and ethical decision making. So, welcome, Kayla.
Thank you.
And now let me go over our learning objectives for today. Participants will be able to identify and articulate multidisciplinary collaboration techniques. So we will talk about some ways that mental health professionals can work across disciplines. Kayla's going to tell us about all the different disciplines that she works with, and it's a pretty extensive team, which is great. Participants will be able to analyze leadership roles and challenges in multidisciplinary settings. And lastly, participants will be able to evaluate the impact of technology on multidisciplinary social work. So I will ask Kayla a little bit about how technology does or does not play a role in communicating amongst teams. Why is this important? Every setting you have to probably work across disciplines in order to do really quality care for clients. So it is about working across different disciplines, and that's going to be really holistic for the client. So every profession has a different skill set, they have a different expertise, and by coming together, it's going to enhance our client outcomes. So the hope is that client outcomes would be improved. It's about efficiently using resources, right? So when you're working with a multidisciplinary team, you want to make sure that the right person is doing what they need to do to best support the client or the client system. And it's Kayla's going to talk to us about this. They meet every single day, Monday through Friday, which is great, but it's a lot about being effective with your time, your resources, in communication. And then lastly, professional development and learning. Multidisciplinary social work, it offers so many opportunities to learn and develop. I'm sure Kayla will tell us about, she's probably learned a lot from the different professionals and across disciplines that she's worked with. Very different from the work that I do. So I'm really interested to learn more about her work with substance use and addiction and inpatient mental health. So that's a little bit about where we're headed today. And with that, I want to jump right into getting to know you and your work a little bit more, Kayla. So, welcome and thank you for taking the time to talk with us today.
No problem. I would say my work every day is not the same, especially being inpatient. So every morning we meet from 8 to 8:30 for the MDT team. And that's like leadership, like my supervisor, therapist, case management, nursing, and sometimes we have like different disciplines come. But after that meeting, leadership meets from like psych, recovery support staff, nursing again, supervisors from clinical, and the CEO comes as well every day. So
Yeah.
she so she's aware of like all the operations. So with those meetings, it just talks about discharges, what's aftercare look like, what medications are they taking, medication assisted treatment. Are they on that? Are they not on that? What does that look like for them? And with those meetings, it just helps us figure out what needs to be talked about during sessions, what does family be roped it on? Because some families don't know everything, or they only know like, okay, mental wise they're okay, but what are they doing after they leave inpatient treatment?
Mm,
Those help us all get on the page and help us figure out where are they going. And I also hold groups as well too, which they like to know group attendance for
mm,
them. If they're engaged in treatment, what's that like for aftercare? If they're not engaged in treatment, are they depressed? Are they having suicidal thoughts? What's going on with that? So everything plays a part with each other. We're all intertwined in some way every day.
yeah. So, tell us a little bit about your role, how you got into the world of substance use and addiction, and what your role is as an inpatient therapist.
I came into substance use because I used to work at a psych hospital that had a detox unit. So I would see
Mm,
detox frequently. And I was like, okay, well, seeing detox is getting repetitive a lot because you see the same people coming in and out, insurance denials, and it's like, where are
mm,
they going to be? Now, when I entered with the VA, my colleague was like, oh, come work at RCA because it's a great place where you can learn a lot and we're all work together. So I applied and I started in this field. And also, I have family who deals with the battle of addiction as well. So I figured this would be a good way for me to learn as well too. And also, just coming here, I've learned a lot like medical terms, nursing
mm.
terms, just like MAT and what that provides. We tend to think about MAT as like, okay, you get the shot, that's all it is. But there's way more options, way more different things and avenues they can take. I learned about more than just AA and NA. There's smart recovery, Dharma, like different ways for them to have that extra support.
Yeah. And I will just say from personal experience, I don't know many people who addiction has not touched their lives in some ways, right? Whether it be family or friends or professionally. So I think it is so important that even if people don't directly work with this, it does touch people in some way or another. Um, so tell me a little bit more about who would be someone you might see. How does someone get into inpatient services with you? What is that process like?
So before they come into treatment, they call the numbers, like a general number they have, or some people do have BDOs that they are connected with depending on their region, and they'll call into them and they'll say, hey, like I'm struggling, I need treatment. What will that look like? And sometimes that looks like maybe, hey, you just need a phone call, you need outpatient services, or that looks like you need inpatient treatment. And when they get here, then they go through the admissions process, strip search, all
Mm,
of that. And then within 72 hours, therapists make contact with the patient, say, hey, I'm part of your treatment team. I'm Kayla. Nice to meet you. And I help them go through their BPA, the biopsychosocial. Then we develop a treatment plan, which has like generic goals, like meet attending groups, meet with therapists, meet with case management until we start to do that work. Because sometimes they come into treatment saying, I'm not going to tell you my whole life story because I'm only here for X amount of days, which is, we got to meet them where they're at. If not ready to talk about that. Sure. If I'm just checking in every saying, hey, how are you doing mentally wise? Like I will do that too. Cause some people don't want to open up that can of worms here and then start all
mhm.
over level of care, which I understand that completely.
Yeah. You said BDOs. What does that stand for? I'm sure it's a field where there's tons of acronyms.
business development officer, which just means they help people get into treatment. Like I'm in Maryland, so like in Maryland, there's a BDO for this region that he connects with people once they leave, checks in with them once they leave as well too.
Okay.
So
Okay.
they follow their whole continuum of care sometimes.
Okay. And we talked about this, Kayla. Tell us a little bit about how long an average treatment stay might be. And we talk about this in almost every clinical conversation I have. Insurance can be a barrier, but tell us a little bit about what the average stay is and when more long-term stay might be warranted.
The average stay here is 30 days. We do have people that stay longer than that, like 30 to 50 days, depending on insurance, but sometimes we will help them get to that next level of care. Let's say the bed's not ready for them to go bed to bed. We will make sure they have that smooth transition, not just be like, okay, today's your day, like, time to go, because that does happen. Like insurance is a barrier for some people, especially when they come to treatment multiple times, they will say, okay, it's time to go. And sometimes that's where the MDT the MDT team comes in. That's where it's beneficial to say like, hey, like we know it's a pattern where they come into treatment, but we are trying to advocate for them to stay because they are going to go bed to bed.
Yeah. And insurance wise, some people are they not ready to discharge at the 30 days, but due to insurance, it just is the barrier and there's no way that they can stay longer.
Sometimes we work with people as well too, and we will just hold them and work with them more to get to that next level and just say if they're not ready, we can't force people to be at that level yet to where they say, okay, so we will work with them and figure out what that barrier is to why they're not ready to leave yet. That's what the need team comes in as well to figure out like, is there a barrier? Is it just more so mentally they're not ready and it's just anxiety to leave and new? So we work together on that as well.
It makes me think a lot of like the social work helping process, right? Termination's a phase, and some people are not ready to terminate. Others are like, "Bye, see you, I'm good," and others, it's scary sometimes, especially when I would imagine in an inpatient setting, they have a lot of support from the multidisciplinary team.
Yeah. And we're
Okay.
all right. I'm I'm in one place, kitchen shift somewhere else. Nursing's always available. Like someone's always here from staff and from the team to be like, hey, what's going on? And touch base with that person as well, too.
So we've touched on this multidisciplinary teams. How would you define a multidisciplinary team? Obviously, it's working across disciplines, but what does that look like? What does that mean? And on a day-to-day basis for you in a treatment center, who might be on that multidisciplinary team?
Honestly, to me, it means just collaborating on patient care because sometimes we all come from different professions and it's hard for them to understand why I'm saying one thing and why they're like, okay, well, you're saying from clinical, but from medical, here's what it
Mhm.
is. Plus that chance for open communication for us to understand where each side is coming from. And with our MDT team, it's myself, case management, nurse case manager, clinical supervisor, and the CEO switches back and forth between the two different meetings because we split up, but between us to the CEO does come in and out as well to our meetings. And the RSS supervisor, which is recovery support staff, they check on the well-being of the patients throughout their day. Like just scan them, make sure they're, alive and breathing and programming. So she's a part of that as well. And with that, it just brings everybody together for like sometimes they don't understand behaviors,
Mhm.
have no intention behind them. It's just what they're used to doing. And being an inpatient is a new environment and it may be common, which scares people. So having that team allows people to know, like, hey, this behavior is not a personal attack on us. It's just what they're used to.
Right. And as mental health professionals, we understand that a behavior is a sign of communication, right? Or it is a defense mechanism, or it is signaling safety. Where oftentimes maybe a medical professional is like, it does not make sense, or it's defiant, or something of that sort, because they don't have that knowledge that we do, where we know all behavior is some way of the client communicating with us.
Yeah, absolutely.
So tell me, you were telling me you have a really interesting model about your daily meetings with the MDT and what those would look like. There's probably, you probably now have a routine of how you do those, but what do those look like on a daily basis?
So every morning we come in and we review the discharges and make sure they're confirmed for at least a week out to make sure transportation has enough time to get the ride set up and things like that. Then we go through, it's called huddle, where we go through each patient, not each patient, but like certain patients that are on our radar for like behaviors or wanting to leave treatment early against advice, and review that, review what's going on with that. Is family involved? Is aftercare in place? If they were to leave, what does that look like? Then we go through like any parent concerns where patients tend to pair up with each other, like, and form a rehab relationship. We
Hmm.
review that during this, so that way we can understand, like, okay, we know if we see these two together, we know like it's not really a positive thing sometimes. Then we just go concerns that come, like maybe this person had a rough phone call and needs extra support, or this person has to call their child every night at 5 o'clock. We make sure that's alert for all of the team to know, because we use Microsoft Teams to
Okay.
communicate well too.
And that we're gonna touch on that. You have to communicate, right? There's lots of different players. So you use Microsoft Teams. How are you using technology in real time to help you all communicate other than Microsoft Teams? Or how do you utilize Microsoft Teams in a way that is going to be beneficial to all of you? Because it's a lot of people to coordinate.
It is. I would say Teams is probably the most beneficial because it's the quick chat and you can see
Yep.
everything at people. We still use email as well, but sometimes people leave, their laptops behind. They're not always open email. And the phones, no one's always sitting in their office due to us always being up and moving. So you can call, but you may not get a hold of somebody. So I feel like Teams is probably the most efficient thing we use because it's quick. It's like texting in a way, it's right at our hands most of the time. It's just an app on the phone.
So you guys can access it from your phone, which is great. And I utilize something called Slack, which is similar to the chat feature in Teams, and it's great because it is real time, right? And it's hey, you can ping people too. It's hey, I need to get a touch of Kayla, so here, do you have 5 minutes? Oh, all right. What's your schedule for the day? Do you have people that contact you that maybe outside of the multidisciplinary meetings maybe need to like chat with you about something or debrief or get advice on something?
Yeah, usually with that, just go face to face because sometimes not everybody has like nurses have access to a phone all the time and they don't have offices. I usually like go face to face or say, hey, when you have time, would you like to talk, or just try to find that time throughout the day. And we
Yeah.
use a system here called Avatar to make our schedules for like how we schedule patients as well. So with
Okay.
Avatar, people can see our schedules, which is nice too. So they know like,
Yeah.
hey, meet with your therapist at this time and maybe make sure you make that appointment. So everybody's in the know here, which is good. It's good to have that.
Yeah, and you can see people's schedules, so it's, "Oh, they're in a meeting right now," or "Now it's not a time that they're available." Which do you find that that actually eliminates some of the barriers that you might have with reaching people or, not being available at certain times?
I'll say so there's a concrete answer to myself and to the patient sometimes. Like saying I don't know sends people into anxiety mode. So saying like, hey, they're in the meeting right now, but let's try it this time when there's a gap in between, we can try it then.
Yeah, and that's so helpful that you said it also helps the patients too, because they might say, I want to talk to this professional, I want to talk to this person, but you can say, hey, they have in their scheduling, they have free time at this point in the day, and it helps alleviate some of that uncertainty and some of that. When can I get in touch with them? Urgency.
Yeah.
So obviously it's important to work across disciplines, but why does that matter that we work with across disciplines? How does that help the clients? Obviously it's great for practitioners to be on the same page, but how does that affect client care?
I'll say it's the whole treatment care that they need to have before moving on to either going home or to their next level of care. Because if I just focus on mental health part and medical is not addressed, that could pop up or vice versa. So you gotta address it all aspects for them to have a healthy life, because sometimes they may forget like, oh, I do need to take care of myself medically and physically and mentally and emotionally. And they forget, like they focus so much on one thing, they forget like, oh, it's a whole encompass of everything. So having that whole MDT team come together, she was like, hey, we're all are separate, but coming together, it makes you a whole. It's like a whole person treatment approach we do here.
Absolutely. And so I also assume that in substance use, the medical side is very important. So what are some of the ways that being in touch with the nurses or doctors is crucial really for some of your clients that you see?
I would say know what medications they're taking and know what they're on and the side effects and let them know like, hey, if you experience this, this, and this, maybe you're not withdrawal, maybe it's a side effect to your medication because they
Mm,
tend to post-acute withdrawal, but sometimes they're dizzy because the medication's just a side effect or something new they never been on before.
yeah.
So and access to the nursing report sheet, which I like personally because it shows me what taper they're on, how long their detox is for, what are they allergic to, like things like quick little things we need to know to help them understand like why are they feeling like this, maybe mentally wise they're going through it because the side effect was depression. So maybe
Mm.
they're happy, but the medication is making them depressed. So I feel like it's good to know that from medical and nursing for them to inform us.
Yes, and it's sometimes trial and error, which I'm sure the psychiatrists or the doctors need to trial some things. Oh, this works, this doesn't work. Is it helpful for you to see if medications have changed because there was a side effect to that?
Absolutely. I always put it in, I always document in my note too when they report these side effects. So that way I know what date and what time I met with them and follow up with them, hopefully within a week to figure out like, okay, the medication changed from the last time we met and how do you feel with that? If it did not change, has it subsided? It's
Mm.
absolutely follow up with that.
How does appetite or how often they're having meals, does that play into anything? Do you need to know about appetite and how they're eating or not eating? How does that work and how does that play into the multidisciplinary team?
I would say yes, because sometimes other disciplines will deem it as an eating disorder, but really they just are not eating because they can't hold food down due to the detox. So I would say
Yeah.
sometimes they say, oh, not eating because there's an eating disorder. And I'm like, well, are they not eating or are they trying to eat minimal? And
Yeah.
we're assuming it's an eating disorder sometimes.
Yeah. And also, this is not my wheelhouse. This is your expertise, but I assume that there could be major appetite shifts if someone is detoxing, and that could be a huge thing too, right? Their body is responding in a certain way.
Absolutely. I've seen people say they're like, oh, they haven't ate in days. And I see them eating. I'm like, I've seen them eat. They just can't hold the food down due to their body. One, I mean, used to having access to all this food, and two, them having like a hearty meal within X amount of time they haven't been eating as well.
Yeah, and we know that when someone is using a substance, they might have while they're using, they might have be overeating or undereating as well. The actual substance that they're using may have effects on appetite or a variety of different things.
Absolutely.
So that's really helpful. And a couple more questions about your work. Tell me about how you communicate because medical professionals sometimes use advanced medical knowledge jargon. I'm sure nurses have a different jargon that they use. We have certain different languages that we use, and we're utilizing all these different approaches. How do you communicate? And was there a learning curve to learn all of the different language and ins and outs of working at a recovering center?
I would say absolutely. Learning step down date, MAT, the different types of medication provided. I'm like, okay, I said I need a sheet with all these breakdowns. I mean, they give us a sheet with different medications and what they do and what are they for. And with communication, I keep it very like I break it down and make it where it's just casual conversation. That way, stand that. Like I don't need to use fancy terms or like dialectical behavior therapy. They're like, what is that, Kayla? And with them, we said, hey, we don't know all medical terms. Like you can't talk to us or to the patients like that. Sometimes they're like, they told me all this stuff. I don't know what that means. And I'm like, I don't know what that means either. I'm like, let's ask them together what that means because we can both learn together sometimes.
Yeah. And are you as the therapist, the social worker, do you sometimes have to bridge that gap between the patient and helping them understand that the jargon can be very medical heavy and helping them say, "Hey, I don't know, but I can find the answer for you."
Yes, I feel like sometimes patients get scared with inpatient being able to advocate for themselves. And they feel like
Mhm.
they can't ask questions. I'm like, well, why not? It's like it's your treatment. You're getting these services. This is your right to ask questions. I'm like, I can help you bridge that gap too, to where you feel comfortable. And I'm like, ask them, hey, what's this medicine do? What am I even taking?
Yeah. And I think that's such an important skill because it's probably scary to say, "Oh, well, I don't want to ask," or there could be shame around it, right? Oh, I should know about this as well. Tell me a little bit. this is outside the professional MDT, but how is the client part of their own treatment, and how is the family incorporated? Because that they're important too to the team as well.
Absolutely. So the client, their aftercare plan is completely what they feel comfortable with. I give
Mm,
my recommend as this is what I recommend, but don't feel forced to have to do this. It's like you're the one that has to do it. I cannot go there and do it for you. So I
yeah,
try to help figure out what will these options look like. Like if you do this, what would that look like in your everyday life? And with families, I include them in that conversation too. Like, hey, your loved one's about to come home soon. Here's the aftercare plan. What do you need to see from them in addition to this aftercare plan?
mhm. And once again, advocating for sometimes parents or family members, they probably need some support too. What does this medication mean? What does this mean? This is a lot.
Yeah, and with families, the good thing is too, they have family support groups. Like,
Mm,
they have Al-Anon, Nar-Anon to help with the family support. And they go through the same 12 steps that they work on as well too. And they have smart recovery for families. They have recovery dharma for families. So I try to give them those resources as well. Let them know, like, hey, there are supports out there for you too.
yeah. It's really, like you said, a holistic approach. And if someone within the family can be supportive, you want them to be in also involved so that they can help the client once they leave the treatment center. More questions. Do you have in your head an example of a time that the multidisciplinary approach, the team worked really, really well together to make sure there was optimal care for the client? And you can be general, but does something stick in your mind of like that went really well?
Yeah, I would say there's this patient who was very resistant to aftercare. And even though he left with no aftercare, he still left with no aftercare. I like how the team just came together. Like it was myself, both of my clinical supervisors, director of nursing came down. All the nurses he ever worked with came down. Like a lot of people just came around because I was like, I can't do this on my own. It's like me by myself. He does not care what I have to say right now. It's like he is not my biggest fan. So everybody just coming around and be like, okay, we can offer what we've seen working with him in the past and just pull together. Like just seeing that was really nice to see because they're like, we know we all have him at different points when he come in and out of treatment, but we can all pull together and be like, look, we all seen different aspects of your journey here and just
Yeah.
pull to figure out what's going to be different this time. So I did like that. I like that approach that we took as well.
And was that beneficial, obviously, for the client, but for you to feel like, oh, I'm not alone in this? There's other people that like might have a different way to approach this that might be beneficial.
Yes, I find this very helpful because it feels like we do the job on our own as social workers, as therapists. Feel like we're on our own carrying the load because we take on emotional compassion
Yes.
fatigue. We take on so much. It feels like just lighten my load a little bit, and help me. Let me let him see it from somebody else's eyes because he knows
Yeah.
what I'm going to. You're my therapist. You're going to say that. I'm like, you're right. I am going to say that. So having somebody else in different discipline help me out with that was really nice to see.
And just knowing sometimes people respond differently and there's nothing wrong with that. But I have some people that are like, for whatever reason, they feel more confident in speaking with the medical provider, right? And I'm like, that is absolutely okay. I don't take offense to that. And then other people are like, I'm a little bit intimidated to talk to the medical provider. Will you do it with me or will you help me with this? So there's so many different ways that you can approach this that is in the best interest of the client. Where do you find the biggest challenge in working with different disciplines? What is something that's hard or can be a sticking point or a barrier when you're working with some of these cases?
I would think when it comes to the behaviors, like we touched on earlier, they don't get those behaviors are not ill will. Like people are out of their environment, they're in a new environment, they're trying to change their behaviors and work, they're trying to change and work on it at the same time, which causes confusion. Or this is the
Yeah.
first time people have known peace, like it's peaceful here, you're safe here. They're uncomfortable with that. And sometimes other disciplines don't understand that it's a defense mechanism. It could be self-sabotage, it could be various things to where they're like, I'm uncomfortable, get me out of here.
Right. It could be I'm just thinking it could be so many different things, right? I work in a very different space, but all behavior is communication. This could be I'm uncomfortable, so what is my fight, flight, or freeze? I'm going to get out of here, right? Or do you get some some patients that completely withdraw and they seem that they're disengaged, and um other staff members who might not have the knowledge that we do of what the importance of understanding the root of behaviors, they might say, oh, they don't want to be here, they're not invested in it.
Absolutely, I've seen that recently because he was sitting in his room. He would only come out to talk to me. They're like, "Oh, he wants to talk to you," and I'm like, "Well, have you just tried to engage with him? Like, he's not unfriendly. You just got to say, hey, like, how are you doing?' And that will open up that door, and he'll start to come out more." And sometimes they
Right.
feel like isolation is, but I'm like, no, sometimes they're just depressed and they don't know how they got to this spot. So just maybe engaging and saying, "Hey, how are you doing?" Could open up so many doors, which also becomes like frustrating too because they feel like, oh, well, the therapist will handle it because they know they have the skill set, but we all have the skill set to say, how are you feeling today?
Yeah. And do you have to do some psychoeducation to the staff on how to engage people, or have them see it from a conceptualize the case from a different angle? Maybe it's not so much defiance or lack of motivation. Maybe it's X. That's why they are acting a certain way.
Yes, we educate staff frequently. And now we added on teams like a tab to where we tell like trigger behaviors of certain clients with these behaviors. So that way people are aware, like, hey, when they're angry, maybe say, hey, do you want to go outside for a little bit or separate yourself?
Mhm.
Like that's that way they know when people feel triggered or feel targeted, they shut down.
And a lot of times, other professionals might not know that even tone of voice or different things might trigger someone, and it has nothing to do, it's not a personal problem, right? I'm thinking a lot of people you see probably have trauma histories, right? So they might be triggered just by a person in power, or they might be triggered because they had a bad experience in the past with a medical professional. How do you see trauma and like trauma histories playing into how they might interact in the inpatient setting?
I'll say definitely with tone, definitely with how certain people talk to them. They feel like I feel like I'm below them. Like they feel like I'm
Mm,
beneath them. I'm just a number. I'm just here just for them to be here. Or sometimes you see people respond to trauma by people have to come and scan them. You knock on the door, they might reflex and you be like, feel like someone's about to attack them. And I'm like, hey, remember you're in a safe environment. I'm like, maybe before you enter the door, say staff 3 times or let
mm.
yourself be known before you enter so they know like, hey, it's no one trying to hurt me. It's a staff member coming in.
Right, and that is difficult to address, I would think, in a 30-day program, right? There could probably be so much more that could go on with there. How do you work together from the multidisciplinary perspective to work towards discharge? What goes into that? Obviously, would have to probably be medically cleared, but how do you all get on the same page that to say it's time to discharge and here's how you can be successful once you leave our facility?
We definitely emphasize the importance of aftercare, especially if it's just outpatient, even if it's just one-on-one therapy. Just have somebody that extra support to keep you going through it. We always include people with like, here's the discharge date, here's what that looks like. And we always ask family too when they first come in, are they able to return home? If
Okay.
not, what like? So we try to make sure we try to start it early on, like and have those discussions early. So that way it's not a surprise come day 14. They're like, I'm going home. You're like, actually, no, you're not going home.
Don't have someone that has said that you can go home to. What happens if they don't have someone that is supportive, or a place or somewhere that they could go home? Is there a step down, or what might be a lower level of care that's not inpatient, but not necessarily going right out into the community where there might be a higher likelihood that relapse could occur?
There's partial hospitalization program, PHP with housing to where it's a step down from residential, but they program like throughout the day, but they can go to a housing afterwards and have that free time. Or it's more flexible, or they can go to a sober living or to an
Mhm.
Oxford house as well. So there's different options for them to maneuver. Sometimes people do it for like 2 weeks to give their family still that space and time to heal, and then they're like, okay, I'm ready to go home after that time frame. So it
Yeah.
varies frame, but it's a good another next step down from inpatient care.
Right. And do you have some that might do intensive outpatient? So they're inpatient and maybe they're not doing PHP, but now they're doing weekly 3-hour intensive outpatient.
We do see that as well too. Sometimes they go back home after IOP. Sometimes they have IOP with housing now too. We're seeing more of that increase as well.
Okay. A few last questions as we kind of start to wrap up. How do you guys conduct trainings? Because I'm sure there's different mindsets, ways of thinking, ways that people were taught. What are some trainings that the whole team gets that aren't specific to social work or mental health that the agency provides?
When we get de-escalation training, just had a training on our new curriculum for group for dialectical behavior therapy. So we just had that training as well. We also get friendly, not friends training where we talk about like how to build rapport, but make sure the patients understand that we are not
Friends,
friends. We're
boundaries, yes.
yeah, which is important information to have. So we do get some trainings from there too. And of course we have our own CEUs that they provide for us to continue with training, which is good to have.
So it seems that here at recovery centers, it's you want everyone to have all the knowledge that they possibly can, right? Like de-escalation is important. Friends but not friendly. We learn about boundaries, we learn about code of ethics, but some people might not understand that or realize like it's tiptoeing and that maybe it's getting a little bit too much on the like personal relationship side. So that's would you say that educating other professionals on these different important pieces of treatment is something that is of importance to the agency?
Yes, because sometimes it's people's first job being in the field and they want everybody to like, be appeased and be happy. But sometimes confrontation is not always is a negative thing. People are scared that it's always negative. Like sometimes it's healthy confrontations where you just set boundaries and say, hey, this is what it is, this is what it's not going to be. So I feel like the training people understand like we do care for the patient, but we have to hold them accountable, hold ourselves accountable to make sure everybody's safe and doing their job appropriately.
Yeah, and just curious, you said the de-escalation. Is there any piece in the inpatient where there is like a tech or a health tech or someone that can come in when escal like I don't know, I don't want to say security, but someone that obviously you all are trained in de-escalation, but that is kind of the go-to person if behavior does become unsafe.
They are trained, but we are still working on giving them that courage and empowerment to want to continue to de-escalate. Because sometimes people get scared of like they're angry, they don't want to deal with it. Or they say, I
Mm,
want my therapist, and people are like, oh, they want just their therapist. I'm like, no, they just want a listening sometimes. They just want somebody to listen. They don't care who it is.
right. And how much of that goes to building that relationship, right? We're not magical. I mean, I think we're pretty magical, but it's because we take the time to build in the relationship building piece. So that's really important for de-escalation.
Yeah.
My last question as we wrap up is what do you give for advice to someone that I say that everyone's going to work on a multidisciplinary team at some point, but what's the best piece of advice you could give to someone that is working with many different disciplines and different professionals?
I would say be open minded and be willing to learn because
Mm,
I learned a lot. So I would say, and be willing to communicate and be ready to advocate because sometimes you have to advocate for your standpoint, for your clinical judgment, and make them see why you're saying what you're saying.
right. We have a lot of schooling, we have a lot of expertise, and that's important to say, hey, clinically, here's what I'm thinking is going on.
Yeah, I would say those are my top things, right? By working with the MDT team, be open minded, willing to learn, communicate, and advocate. Those are my.
Love that. Perfect. Well, thank you for taking the time to talk with us a little bit more today. And I think you're in such a unique position because you work across so many disciplines, right? That's pretty unique situation. Everyone works with so many different providers. If anyone is interested in some of the resources around community mental health teams, multidisciplinary teams, collaboration, here are the resources that we use to pull some of our questions and our work from today. So go ahead and check those out. And I want to end by thanking you, Kayla, for taking the time, explaining your work and how you work collaboratively across disciplines and with a variety of different people in the inpatient world. So thank you.
Thank you so much. I appreciate it.
Thank you. And for those of you that are tuning in, there will be a post test that you can answer to get your continuing education credits. But thank you, Kayla, and we hope to chat with you again, maybe on a future topic.
Absolutely. Thank you again.
Thank you. I hope you enjoyed the Social Work CE from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post-test. If you're looking for more CEs, check out our unlimited plan. You'll get unlimited access to 150 plus ASWB approved continuing education courses for one low annual fee. We're always adding new courses and bringing on new experts. Did I mention we also have 5 free CEU credits available too? Check it out at agentsofchangetraining.com.